I will be presenting about our month of March, our March to Data Fitness. Paul Nagy, my co-lead with the Evidence Network, will be here a little bit later to help answer some questions as well. But just to give you an overview of what we're going to talk about today, the first thing I want to touch on is how are we defining data fitness this year as it comes to our guidance-driven evidence studies? And really, this is the first time we've done something like this as a community at large. We piloted, like I talked a little bit before, we piloted this approach in the SOS challenge, and we're really putting it to use here in our guidance-driven evidence year. Then we're going to talk about what the role of the OHDSI Evidence Network will be. And if you're interested in joining, I have a couple points on how to join, as well as a quick overview of where we are with the OHDSI Evidence Network. And then I'm going to give you an example of what we mean specifically around data fitness for use, how we're going to be evaluating the databases in the OHDSI Evidence Network against our 14 studies. And I have an example walkthrough and output to go through. So first off, let's talk about what do we mean by fitness for use? Over the years, I think we've really seen the term fitness for use become much more favorable, much more fashionable, because as this large amount of data, large amount of databases become available to us to generate evidence, the question of which databases are best fit to answer which study questions, that becomes much more important. And there are many different ways we can define fitness for use. But specifically, when we're talking about the guidance-driven evidence studies, the 14 studies we're working on as a community, we have 3 different things we're going to be focused on. So the first one is just going to be interest. So which data partners would like to be part of this effort to contribute evidence? Which data partners have the bandwidth? Those sorts of things. We want to make sure we're honing in on those data partners who really want to participate. As I'll get into with the OHDSI Evidence Network, we do not mandate that any data partner must generate evidence for all studies they are eligible for. So we're really going to be focusing on those that want to be part of this effort to contribute. And then the second piece we're going to look at is technological readiness. So data partners that indicate interest are going to be asked to run a Strategist test package to assess this readiness. Now, we anticipate that there will be some data partners who maybe don't get past this step, and that is 100% okay. Really what we're trying to do is get everybody up to the same level so that when the next study comes along, they'll have their Strategist test package run, they will have worked out the kinks in their environment, and they'll be ready to go. So we really are going to be focused a lot on helping data partners get to that point where they can run a study, even if they can't necessarily participate in one or more of the 14 studies we're doing this year. This is going to get everybody on that same level. If you've participated in a network study before, you know that this can be a big challenge, and it can be pretty discouraging when you sign up for a study, you try to run the package, and you just keep hitting against either R errors, or your IT person won't let your package run because it's from some website that they aren't happy with. There's all those different bureaucratic and technological things that we want to help data partners get past. And then from there, we have our study fitness portion. So all data partners, regardless of interest, all data partners will be evaluated against all studies using Data Diagnostics. And this is where we look at all the pieces, all the individual pieces of each of our studies, which of our data partners have each of those pieces in their databases and can be potentially considered to contribute evidence. And as we talk about the evidence network, I'll share a little bit about why all data partners will be evaluated, but this is really how we are planning to move forward with all network studies in the future. And I meant to mention, please stop me at any time if you have questions. I'm happy to have an open conversation here. Okay, so let's talk a little bit about the OHDSI Evidence Network. What is the role of the OHDSI Evidence Network in our guidance-driven evidence effort? And then if you are interested and you want to join us, I have a couple points on how to join, and you will be receiving these slides. Craig will be posting them, so you'll have all the links I have here for you. We've talked about this, on and off over the past, I guess, year or so. We're coming up on a year in July when we really rolled this out. But the idea behind the OHDSI Evidence Network is that we want to facilitate collaborative research efforts across our OHDSI community. And we are doing that by identifying our data partners within our community who are ready and willing to generate evidence. And once we've identified those data partners, we are collecting some summary statistics about their databases. This set of summary statistics is held securely at the OHDSI Coordinating Center and is used to inform network studies. So that's really what we're doing here today, is we're talking about how can we use these summary statistics to help us understand which databases in our network may be best fit to answer each of our 14 studies. And that's why we're going to be looking at all of our databases in the network, even if they don't indicate that they are interested or maybe have the bandwidth at this time. We're still going to be looking at those summary statistics to help inform on these 14 studies, because really this is also helping us understand better the science of data fitness for use. So once a data partner shares with us these statistics, that it's held at the OHDSI Coordinating Center, and it's really nice because no patient level data actually leaves our data partner site. It's really this high level aggregate information that is in compliance with privacy and IRB regulations. So I'm very excited. Currently, we have 42 data sources and 23 different organizations. Now, those two numbers are different because, of course, some organizations have more than one data source in the network. And I'm very excited. So I will share this URL with you so you can take a look. But we started to put some information out on our OHDSI Evidence Network website, just a little bit about the databases in our network, what they look like, and just some high-level summaries right now about the demographics that we are observing in these databases. So you can see here we've got the majority of our databases in the network are electronic records. We've got 9 administrative claims, and then 3 that are characterized as other. For example, one that's in the other category is a hospital billing database, so not exactly EHR, but not exactly administrative claims. You can see our gender distribution across the network here. This is patient count by database. So luckily all of our databases have both males and females. So that's great. We're on the right track. You can also see our year of birth distribution. So these are very similar to some of the Achilles analyses. If you've run Achilles or if you utilize Aries, you'll see a similar graph, but this is being done across all of the databases in our network here. And you'll see a big spike in 1937. I shared this with Paul Naji yesterday, and he's like, why is that big spike in 1937? And we were able to go back and look, and it's because some of the databases in our network do utilize some year of birth masking to protect patient privacy. So once patients get over a certain age, they are given the year of birth 1937 to make sure they cannot be re-identified. And the next 2 graphs I think might be really helpful for some folks. I know there's been some questions about race and ethnicity distributions across the network. So what you can see here is if you hover over the bars, the number of databases that have different races available. I know we've received some questions, over the years around, who is using race, how many databases are using race, what does it look like? So this does give us quite an idea of what we can observe in our databases, and the same for ethnicity as well. So we're going to keep adding to this dashboard. I'm very excited to actually have a way to share this information with the community, and we'll keep adding as we go and as we learn more about our network as a whole. And just to remind you as well, if you want to look at the concepts in the evidence network, the concepts that are available, all the concept counts in the Atlas demo environment are built off of our evidence network as well. All right. So as we move forward with our guidance-driven evidence, we are asserting that you must be part of the OHDSI Evidence Network in order to contribute evidence to these 14 studies we're working on as a community. And this is for two different reasons. One is because we've been working very hard to support our data partners in the network and to help them get up to speed and start to run network studies. And we really want to mobilize our evidence network because that's really the realization of what we've been talking about these past really years in putting this together. And the other thing too is we know that there are many, many more organizations and data sources around the world that are using the OMOP Common Data Model. And if you'd like to be part of the network to support our 14 studies, we welcome you with open arms. We are really trying to build up this resource so we can play matchmaker and help those study leads who come to the community with a research question, find those data partners who are ready, willing, and able to generate evidence. So if you would like to join, there's only a few things you need in place and a few things you need to do. Like I said, I will be sending out these slides to Craig, so he will make them available to you. So don't feel like you need to write all of this down. This is also on our website. But really, you just need to be standardized to the OMOP CDM version 5.3 or higher. And you need approval from a governance entity if required to share this metadata summary statistics with the OHDSI Coordinating Center. And then you also need the ability to run a simple R package against your data. And then once that's done, you run this package and you generate a profile of your database. That profile is simply, like I've been saying, those summary statistics. And then you send it to us via a secure FTP site. We do have an email address there, evidencenetwork@odyssey.org, if you want some more information. And we do have some information on our website as well. So I hope you will join us. As you can see, we are growing rapidly. I think the last time we talked, I think we maybe had 35 databases, maybe fewer. So we're really gathering steam, and it's been a really fun way to get to know different members of the community. We meet once a month as part of the Evidence Network, and we learn about network studies that are going on in the community. We learn about different ways data partners have enriched their databases. We try to answer questions and support data partners where we can. So we really, highly encourage you to join. And even if you don't have a full CDM yet, but you're in the process, hey, reach out and let us know, because maybe we have some resources that we can point you to. All right, so we talked about our definition of fitness for use for our guidance-driven evidence studies, where we have interest, technological readiness, and study fitness. We are asserting we will use the OHDSI Evidence Network to identify data partners who are best fit to generate evidence for our 14 studies. So again, if you would like to generate evidence and contribute as a data partner, you will need to join the Evidence Network. And now I want to talk you through how we're going to use those summary statistics we've gathered from our partners in the Evidence Network to inform on our study fitness. So in our last Evidence Network meeting last Thursday, we went through this with our data partners and our study leads. But I'm going to give you kind of a high-level overview here. So what I'm showing you here is what we call the data diagnostics process. you can see on the left-hand side, we've got all these different database profiles. That is the summary statistics we've gathered from each of our 42 databases. And we compile it together into one table we call our network metadata that sits again at the OHDSI Coordinating Center at Columbia University. From there, what we can do is we have this one nice resource, and we can pass some general input about a study to this metadata and identify for each study that we're interested in which databases have the individual pieces required to generate that evidence. So what we look at are independent values. So if you need only males in your study who have been exposed to canagliflozin, we say, how many males do you have and how many people do you have exposed to canagliflozin? We, of course, aren't building cohorts here. We're just looking at these independent measures across our databases to say, hey, these are the databases that have the individual building blocks of your study. From there, the data partners would start to run the phenotypes and start to generate evidence where you get into those, the actual phenotype definitions. But this gives us a really nice way to highlight those partners that have the pieces required, because one of the things we're really trying to do is cut down on the time it takes for a data partner to join. What we've seen in the past is that oftentimes without this type of upfront assessment, someone might say, hey, I've got data, I'd love to join a study. They join the study, they run all the phenotypes, they run the full study package, and it comes back with 0 persons because maybe the outcome of interest was a procedure that they didn't have records of in their data. Well, they had to go through that whole process of running the study package to find that out. Whereas with this high-level assessment, we could say from the very jump, hey, we don't observe any of these procedures in your database, so maybe be best to sit this one out and go to the next study. And that way we're trying to save time and effort on the side of the data partner, because we really are, we are asking quite a lot of them here in this context. So we want to make it as easy on them as possible. So here's a quick high level of what we are collecting from each of our partners. As you can see here, and you kind of probably got the idea when I was showing you that dashboard, we're collecting some demographics about the database, about the persons in the database. We collect some information about what months, years are observed, how much longitudinal time patients might have in a database. And then we are collecting information about all the concepts. So we're looking at numbers of persons by concept here. So what we do then is to look at the building blocks of a study. We have these user inputs we request from our study leads. And so what we'll say is, please fill out, it's almost like a mini worksheet for all the different analysis variants in your study. What are you requiring of your databases? So you can set your age ranges, the genders, race, ethnicity, calendar time, if you have a specific date that you need included in your study, minimum longitudinal follow-up. For example, a lot of our studies require at least 1 year of look-back time for our patients. You can specify a list of target concepts, comparators, indications, and outcomes. And then you can also specify the domains that you require. And so you can see I have it broken out here by target and comparator, and then outcome. So what this means is if you require a certain domain for your target and comparator, it means that everyone in your study needs to have, for example, a condition and a drug. So if you say I need conditions and drugs at the very least, you're saying everyone in my study needs to have a record of a condition and a record of a drug. But maybe your outcome, like I was saying before, maybe your outcome is a procedure. So in this case, We just need to know that procedures are observable in your database, but not necessarily everyone needs to have a record of a procedure. We just need to know that if a person was to have a procedure, it would likely be recorded in such a way that we can potentially observe the outcome in your data. Similarly, we allow you to specify visits. Perhaps your outcome needs to happen in the inpatient setting. You can specify that as well. So you can say, well, I need the ability to observe inpatient visits in these in the databases eligible for my study, in which case maybe databases that are solely primary care focused would fall out and would not be eligible to generate evidence. So again, stop me if you have any questions. We're doing good on time here. All right, so I'm going to go through one example. This is an example from Chang-Hoon Han from Dr. Chan's lab in Korea. And they are looking at ticagrelor versus prasugrel for patients with acute coronary syndrome undergoing percutaneous coronary intervention with the NACE outcome. In this case, this study has 11 different outcomes, but I've set up the inputs here focused on the NACE outcome. So they specified they wanted patients greater than or equal to 18, so we're looking at adults. They had no requirements on gender, race, ethnicity, or calendar time. But they did have a minimum longitudinal follow-up of 90 days. So they had a slightly shorter longitudinal follow-up than we typically see, but that makes sense for their indication. They are looking at a target of ticagrelor compared to prasugrel. And here we've put the indication as this percutaneous coronary intervention, which is a procedure. So what this will actually do is it'll go through and say, do we observe this procedure at all in the databases in the network? So it'll go through and make sure that we are identifying those databases that have this procedure observable in the data. And then the outcome is the net adverse clinical event. And then in this case, because our indication is a procedure, and we are also looking for patients who have acute coronary syndrome, who have been exposed to a particular drug, we are asserting that for our target and comparator, we need to be able to observe patients who have at least one condition record, one drug record, and one procedure record. So we need to be able to observe all three of those domains for an individual person in the database for them to be eligible to be included. And then our outcome definition does require that it occurs either in the inpatient or emergency setting. So we've put here that our outcome needs to have inpatient or ER available. So that was just for one. I want to give you an example of what this would look like across more than one outcome. So like I said, this study is looking at 11 different outcomes. So here's how this would be set up for 4 of those 11. So you notice here that all these items from kind of like this row down, the TNC domains and up, all those items remain the same because we have all the same requirements of our target and comparator cohorts across all of these outcomes here. But you'll notice for the outcome domains, for all-cause mortality and cardiovascular mortality, we also need to be able to observe death records in a database. So we've noted that here, that while for this outcome in particular, we need to know that a database has death observable. And then you'll see for those same outcomes, all-cause mortality or cardiovascular mortality, we are not requiring the inpatient or ER visit setting here because the outcome is not dependent on inpatient or ER. It just is requiring that death is observable in the database. But for NACE and stroke, those outcomes do need to occur in the inpatient or ER setting. And you can see then the target, comparator, and indication all stay the same. And then for the outcome, we put in the different concepts required for those outcomes so that we can make sure we are observing the different concepts that are required. However, in the case of all-cause mortality, there are no concepts. It's really just a death record in the death table. Right. So with that, I can share with you the example output of what this is going to look like. And here too, any questions, call them out. So I ran Data Diagnostics against our evidence network 42 databases. And I've uploaded the results to data.odyssey.org/data diagnostics. And you can see here the different analysis variants. Got all-cause mortality, NACE, MACE, cardiovascular mortality. I'm just showing 4 here, but if you click in here, we can grab stroke and look at those. Okay, so what you can see here as you scroll down, you can see the database ID down the left-hand side. We have given every database in the network what I call an OEN ID, very creative name of Odyssey Evidence Network ID, but it's just a way for us to mask the names of our data partners so that we aren't sharing any information that they may not want to share up front. So we've masked those names and given them their database identifier. And then across here, what you can see is some different numbers. So what these numbers mean, if it's greater than 0, for example, this one here has a number of 2, it means that 2 of the requirements for the study are not available in this database, specifically for ticagrelor, prasugrel, and the outcome MACE. So there are 2 items in that particular analysis variant that are not available in this database. But for cardiovascular mortality and all-cause mortality, there was only 1 item not available in this study for those 2 analysis variants. So as you go down, you can see those that have the 0. Those databases are the ones that had all items required for that study available in that database. And you can sort. So here I've just sorted to bring the zeros to the top. But you can see too, sometimes there are databases who are eligible for certain analysis variants, but then not for others. So here we're missing 2 items for the cardiovascular mortality and all-cause mortality outcome. And so this is something that the data partners will need to discuss with the study leads as we move forward. So what's going to happen is once we run data diagnostics, we identify those data partners that are best fit for the different studies. There may be some cases like this where a data partner or a database would be eligible for a few of the analysis variants, but not all. So if they are interested in that study, the data owner will need to reach out and discuss with the study lead if that's something the study lead still wants to move forward with. Okay. So then what we can do, we do also have a drill down option where you can choose, let's choose another, let's see. If we look for the AMI outcome, you can see here that this is giving you a little bit more information as you go across about the databases. Let's see here. Okay. And as we keep going, we start to find some that have some items that are unavailable. So let's take a look at this one. So database 1006-1011. So if we click view, we can go in and we can look at what specification or study criteria was passed to the function. So what did we ask for and what was returned and maybe why is it being deemed unavailable? So in this case, this database does not have enough longitudinal follow-up. Only 0.7% of the patients in this database have at least 90 days of follow-up. Our cutoff threshold is 5%, so we're looking for at least 5% of people in the database need to have 90 days of follow-up. So this is deemed a fail, or that the longitudinal criteria is unavailable in this particular database. Let's see, but if we look at another one, let's take a look at one more. We look at 1004-1018. This one had a few things going on. So in this case, if you remember the outcome, we were looking for emergency room visits or inpatient visits. This database does not have emergency or inpatient visits. So this is saying, well, these are emergency room and inpatient are unavailable in this database. So this is not the best database to evaluate for this particular target comparator and outcome analysis variant. So I can just give you a little bit more information here. And then because of that, we were looking at the sample size. Because there are no inpatient or ER visits available and the sample size is low, it is again failing. So one thing I will note, you might be wondering why we put a sample size criteria here. What we've seen in the past, and this is kind of leaning on work from Martijn and Mark and Patrick, when we run a comparative effectiveness study and we are doing propensity score matching, what they have observed is that you need at least 1,000 persons in your target and comparator cohorts in order for those propensity score models to converge. So if something falls under that 1,000 threshold, we do note it as not having enough patients available to fulfill that requirement. So depending on the study, this is something we could relax. So if it's a characterization study versus a comparative effectiveness, we do have the option to relax this here. Great. Right. So that's essentially what we're going to be doing. The way this is going to work is probably tomorrow, I'm going to be sending out some information for our study leads. I'm going to ask them to fill out the template so we can run data diagnostics for their studies. And we're also going to be sending out the information for how data partners can run the Strategist test package. And I'll be putting that on the forums and on Teams as well. So if you are a data partner and you're curious about running Strategist, but maybe you're not quite ready to join the evidence network, which I understand, I'll be a little sad, but I totally understand. If you want to run Strategist on your own, you'll have the option to run that test package as well. Then once, while our data partners are working on their Strategist test package, and I am working on running the data diagnostics for each of our 14 studies, we'll identify those data partners and databases that are best fit for each of our studies, and the study leads will receive the email addresses for the data partners that meet the criteria. So each of our data partners have an odyssey.org account. So for example, Johns Hopkins is jhm@odyssey.org. So our study leads will receive the information for how to reach out to data partners that meet their criteria. And then data partners will also get the information for the studies that they align with as well, just so that they can get a little bit more information about each study before they decide. And then once data partners decide which studies they would like to join, they'll run the studies using the Strategist template provided by the study lead. So at this point, they should have already run their test package and worked with Anthony Senna to help get it working nicely in their environment. And so they should then be able to just hit the ground running and run the study as provided by the study leads. So that's about it for me in terms of how we're going to be assessing data fitness for use, how we're defining data fitness for use as it comes to our guidance-driven evidence network studies, and then how we're going to mobilize the evidence network to really participate.
Great, thank you, Claire. As Claire mentioned, she'll send me these slides. I know there's a lot of great information presented here, so the recording will be on the community calls page and our YouTube channel as well this afternoon. We do have 15 minutes here. There wasn't a lot. I know a lot of people were really listening, so there wasn't a whole lot in the chat. So are there any questions either related to the evidence network, the data diagnostics process, or anything else? Claire, do you want to give a sense of what ASIA will be doing next week? Because I know that's kind of part of the whole March to Data Fitness.
Yes, so ASIA is doing a really great job. So ASIA is running she's building a network of cancer databases, and they have a study-a-thon coming up in Helsinki at the end of March. And if Asia or Christian Reich are on and want to correct anything I say, let me know. But Asia has something really interesting that she's running that I'm hoping to steal some of her methodology to help us understand the databases and the evidence network as well. But they have a method where they are looking at cancer concepts in these databases, and they're looking at different cancers that those databases represent. So she has some really cool charts that show, well, these databases are really focused on lung, but these over here are really focused on prostate cancer. So she does some really interesting work looking at like the overall concepts in the database and trying to understand, what cancers databases would be best fit to study. So I'm really excited to have her, show the community what she's been doing, because I think it's fascinating and definitely something I want to learn from.
So that will be next Tuesday's community call.
That'll be next Tuesday.
Yep. Cindy Kai put in the chat, will there be office hours for study leads who might need additional help outlining these database diagnostic components for their study?
Yes, we have office hours every Friday from 9 a.m. to 10 a.m. Eastern, and I will put those links to that on the forum, as well as I'll send those specifically out to the study leads when I send your instructions to write out your diagnostic settings. I'll also send you the link to those office hours as well. That's a great call out, Cindy. And those office hours will be open to data partners as well if you have questions about running Strategist. So it's gonna be doing double duty, but I think we'll be okay.
Great, thank you. And a reminder, we will all have a Strategist specific session in May. There's some new updates, new things about it. So April 8th will be a full Strategist session.